Therapeutic Interventions. This content corresponds with Chapter 8 in the Foundations of Athletic Training, Prevention, Assessment, and Management text. Once an injury has occurred, the physical therapist, athletic trainer, or healthcare professional must develop a rehabilitation plan for the individual. There isn't any cookie-cutter method to determining rehabilitation. Everyone needs to be treated like an individual. Everyone responds to injury different. Tissues heal at different rates, and some people are more motivated to return to their pre-injury lives than are others. The ultimate goal of rehabilitation is to return the injured person to pain-free and full functional activity. When we treat an individual, we need to look at their overall well-being. It is important to understand that people process injuries in much the same way as the grieving process. For many athletes, being an athlete is part of their identity. When you ask many high school or even younger individuals to describe themselves, if they participate in athletics, it is commonly something they will use to describe themselves. So for some, an injury can mean a loss of an identity. We see the same phenomena in professional careers. When people are injured on the job, it can be a very difficult psychological process as they typically self-identify in their career. Kubler-Ross developed the stages of the grieving model. This is sometimes referred to as DABDA, although isolation has recently been added to this model, now creating DIABDA. Denial is a refusal of accepting the injury. An athlete or individual may continue to walk on a broken limb or sprained ankle or continue trying to perform tasks because they don't feel like they're really injured. Isolation can be from embarrassment or denial. We see a lot of isolation after people faint or lose consciousness. It is an uneasy feeling when you wake up and you have no idea where you are, what happened, or why people are staring at you. When an injury occurs, the body systems are elevated and the fight or flight mechanism kicks in. People either get angry and combative or they try to remove themselves from the situation by fleeing. I had one friend who was performing a gymnastics routine and struck her arm out to catch herself, and she ended up breaking her arm. Her arm was flopping around, obviously broken, and her reaction was to run to the bathroom and hide in a stall. Anger is another response of grieving. The fight or flight mechanism kicks in as an involuntary response. It is your body's way of protecting itself. Injuries and illness can make normally passive people become very aggressive. One rodeo event I was working, we had a bull rider get knocked out after hitting his head with the bull. When he regained consciousness, he started swinging on the Justin Sports Medicine team who were trying to help him. It was a very abnormal response for this individual. Bargaining commonly occurs when an athlete or individual tries to negotiate with a therapist regarding time off. An athlete might suggest if they take the week off, then they could play in the final game of the season. Or if we let them play this week, then they will take the entire next week off. Depression can occur for several reasons. Being isolated from a team or job can make a person feel very disenfranchised. They may no longer be the starter or get the attention that they once did. They may feel left out of meetings, friend groups change, and sometimes social support systems fail. Depression is a very common occurrence among injured individuals. Depression may also appear during the rehabilitation process when an athlete or individual isn't seeing the progress that they would like to see. They may feel like they have plateaued and are not continuing to get better. It is very important to set goals with our patients so they can see changes too. Depression is also very common with life-changing injuries. For example, I have worked in several places in which we have had an athlete who has had a life-threatening or life-altering injury. A football athlete broke his neck as a result of improper tackling. A once healthy, normal, whatever normal is, young athlete is no longer able to walk, talk, or even care for himself. His dreams of once playing professional football are gone, and he has to readjust to an entirely new set of life goals. For many athletes, that kind of dramatic change can be very difficult, and depression is very, very common. Acceptance is usually the final stage of the grieving process. Acceptance that an injury has occurred and the rehabilitation process has begun. Some people think that this model needs to occur in a linear pattern, but it isn't that predictable. It is difficult to say if a patient will move through these stages in a specific sequence or will even have to experience all of these events. Although most people do go through most of the stages, it's unclear why certain people do not go through in a linear pattern or why they skip some stages altogether. Everyone reacts different to injury. The reaction to injury depends on multiple factors. The first factor is personality traits. People who are goal-oriented are very motivated to get better, but may also be difficult as when they aren't reaching specific goals, they may get very frustrated or they may work excessively hard and push themselves too hard to get better. The coping mechanism of individuals can be a very important factor. Individuals who have been injured previously or who have experienced loss and have some context for the injury. This can either be good or bad. If the context of the injury process went well, then the person may be pretty optimistic towards this injury. If it did not go well or lasted a lot longer than the person expected, they may be very difficult and not be very happy about the injury process. Personal factors are also important. Anxiety, self-esteem, motivation, locus of control, being either an introvert where the patient wants to be in control of everything, or an extrovert where the patient feels like everything is beyond their control, and their social support. Situational factors include the type of activity the patient is doing, the relationship the patient has with coaches. This could also be the relationship a person has with a supervisor or boss, the nature of injury, timing of injury, for example, what part of the season the injury occurred in, or the level of the athlete, freshman versus a senior, and the role on the team or within an organization. As difficult as it is to believe, some people use injuries to keep themselves from going back to work or sports participation. As we try to help our patients move through the rehabilitation process, it's very important to educate our patients about the injury. It is also good to explain the healing process, the treatment and the rehabilitation options, and to fully discuss and answer all questions that the patient has to keep them as an active part of the rehabilitation process. It is good to set goals with the patient. The clinician or therapist cannot be the only one to create goals. The goals need to be important and something that the patient wants to accomplish. The clinician or therapist can help organize and drive the important goals, but if it really isn't important to the patient, then it most likely won't happen. By including the patients in the rehabilitation goal setting, it provides the patients with a sense of control, which is very important as many patients feel very out of control in the injury process. Goals need to be SMART. SMART goals are specific, measurable, attainable, realistic, and have a timetable or can be completed within a specific period of time. It is important to create short, intermediate, and long-term goals with the patient. Short-term goals may focus on little things but can be accomplished quickly. For example, someone who is just injured, a common short-term goal is to decrease pain or increase range of motion. Intermediate goals are goals that are hoped to be accomplished during the rehabilitation process. Some intermediate goals could include getting a patient to return to full weight-bearing walking without any limping or compensation. Being able to walk might not be a long-term goal for an Olympic basketball athlete, but it is a milestone in the rehabilitation process. Long-term goals should focus on the return to activity or return to play ideal. For that Olympic basketball athlete, it would be very important to regain running, cutting, jumping, shuffling, and many other sport-specific activities prior to release from rehabilitation. After an athlete is injured, they may develop a fear of risk-taking. It makes sense that the athlete might be fearful of cutting activities if they had ruptured a ligament during those activities. However, if the fear of risk-taking is not addressed, the athlete could re-injure themselves upon return as they may try to avoid situation and or be paralyzed by the fear of re-injury. It is vital to work with the athlete's level of confidence and try to get them to perform tasks in controlled environments prior to sending them back to the uncontrolled environment of the real world and sports. The social support of individuals is one of the most important coping strategies. Getting coaches, teammates, family, friends, and others involved in the support of injured athletes is very important to the successful rehabilitation of athletes. As an athletic trainer or other healthcare professionals, it is not our job to deal with the psychological problems of an athlete or an individual has. Psychological issues are very common among athletes. Rather, the role of the athletic trainer and many other healthcare professionals is to be a second-level helper who is able to identify psychological distress, provide education, support, and make referrals when appropriate to mental health professionals. Our job is really to identify when psychological conditions occur and to refer athletes to the right resources to get them help. We are a part of the psychological response team, but sometimes the issues people are dealing with are way beyond our scope of practice. When you're considering referring an athlete for psychological services, it is very important to keep the line of questioning non-accusatory, open, and non-confrontational. I would recommend using the acronym ORS when asking questions of patients. Ask them open questions. When you ask certain questions, there are not a lot of answer options. My favorite is when asking a young kid how their day went at school. A parent might get a child to mumble good or sometimes even just a grunt of acknowledgement. But how would the response change if the parent asked a slightly different question? What was the best thing that happened today at school? Or where were you when it happened? Now the parent might get a much better response and might get more details. Be affirming. Whether you agree with the person's comment or the way they feel or not, the worst thing you can do for a person is to invalidate their feelings or tell them that they're nuts or crazy. You can affirm and validate their feelings very easily by telling them that you hear what they're saying. For example, if an athlete is dealing with an eating disorder and sees themselves as fat, and all you see as the clinician is skin and bones, you could affirm the athlete's fear of being fat by saying that you understand that it is the way they feel. By validating their feelings, more people are willing to open up. Be reflective. Open listening is important. So is summarizing. Listening to what the patient is saying and then repeating it back to them about what you are hearing can be a very powerful interaction for a patient. As a clinician, it can also give you the opportunity to confirm what you heard and identify what the biggest issue is for the patient. There is nothing wrong with recommending counseling or other services. Educate patients about the benefits. Keep things positive. Follow up with the patient and continue to provide support through the rehabilitation services. Many athletic trainers joke that they feel that they are a jack of all trades. Sometimes we are a therapist, sometimes we are a counselor, sometimes we're the friend, sometimes we're the authority, and sometimes we're the enemy. It's a very difficult job to have and can get complicated to determine which hat you are wearing at the moment. There are many different types of healthcare professionals, and therefore it can be helpful to understand some of the most common people and what they are trained to do or the services that they provide. A psychiatrist is a licensed physician who is trained to diagnose and treat mental illness, including the ability to prescribe psychotropic medications. A psychologist is a licensed professional who is trained to conduct psychological testing and to assist in the assessment, diagnosis, and treatment of mental disorders. A counselor is a licensed professional who works in a variety of settings and is trained to provide therapy. To ensure that the psychological aspect of rehabilitation is addressed, it is important that goals are set. We also want to ensure adequate social support. Within the rehabilitation process, teaching patients mental skills can help their injury rehabilitation and overall well-being. Breathing techniques focus on abdominal breathing. When a person breathes from a chest, it involves accessory muscles. If you put one hand on your chest and the other hand on your belly and breathe normally, which hand rises? Does the hand on your chest rise? Does the hand on your belly rise? Or do they both rise? If you are breathing correctly, the hand on your belly should be moving. You should be using your diaphragm to breathe. If you watch babies, they utilize this diaphragmatic breathing. Somewhere in our development, many people lose this skill. Diaphragmatic breathing can aid in relaxation and decrease blood pressure. Relaxation is important to healing. When most people think about rehabilitation, we think about the exercises. However, rest is just as important to the healing process as the exercises are to recovery. Our body needs rest and relaxation. Imagery is getting the patient to imagine themselves in a positive situation. For example, a basketball athlete might imagine shooting free throws and the ball going in the basket. Positive self-talk is about teaching your patients to be positive. They shouldn't say that they cannot do things. Positivity is contagious. So as a clinician, it is important that you bring a positive attitude to the rehabilitation setting. In addition, a patient who engages in negative self-talk is actually sabotaging their rehabilitation. They say they can't do things that you want them to. If an athlete can't do it right now, we need to change the conversation or tell them that we are working towards it. Don't use words like can't or won't. Documentation of the rehabilitation process is vital to potential tracking of injury progression and may be important to reimbursement. If a physical therapist cannot describe the improvements a patient has made, why would a physician continue to use this physical therapist? Would the insurance company want to reimburse someone if they are not making progress? Would the patient want to keep coming in for treatments when they aren't seeing any progress? The simple answer is none of this will likely happen if we aren't documenting the progress of our patients. It is common to use the acronym SOAP when documenting injury rehabilitations. SOAP stands for Subjective, Objective, Assessment, and Plan. Subjective items are things that the patient says. Can you tell if someone has a headache? Well, you might be able to see them squinting their eyes or grabbing their head, but how do you determine how badly their head is aching? We use what the patient tells us as an important information gathering in the subjective assessment. A patient could tell you that their headache feels like their head is in a vice grip, or that an ice pick is stabbing them in the back of the eye, and that paints a very descriptive image of the pain and injury that they are describing. Objective are things that we can measure. We can commonly ask people to rate their pain on a scale of 1 to 10. A 1 means that there is little to no pain, and a 10 means that the patient needs to be taken to the emergency department immediately. By ranking the pain, we can compare pain levels from day to day. Subjective and objective portions of documentation may overlap. For example, we can look at our right and left leg and we may see swelling, which would be documented in the subjective portion. The patient may also complain that their skin feels tight and that it feels swollen. A clinician could actually measure the swelling by taking a tape measure and measuring how much swelling is present and giving it a number. This would be documented in the objective portion. Assessment is determining what you think is wrong with the patient. It is okay to make clinical decisions and make a clinical diagnosis. A clinical diagnosis is made typically by an athletic trainer. A medical diagnosis is the actual diagnosis, which is made by a doctor. Since all patients aren't sent to a doctor, sometimes the clinical diagnosis is used to treat the patient. The plan is figuring out what should happen and how to treat the injury or illness. When developing a rehabilitation program during the plan, it is important to remember the 4 phases of rehabilitation. The first goal is to control the inflammation. The second goal is to restore the motion to normal levels. The third goal is to develop muscular strength, endurance, and power. And the fourth goal is to return the person to sport, physical activity, or activities of daily living. This cartoon depicts the 5 Greek caricatures representing the cardinal signs of inflammation: heat, redness, swelling, pain, and loss of function. Goal number 1 is to control inflammation. Controlling inflammation should begin right after injury. We use the acronym RICE, or PRICE, or RICES. PRICE is protection to brace or save the area from further injury, restriction of activity or rest, ice, compression, and elevation. RICE stands for rest, ice, compression, and elevation. Some people refer to RICES, which stands for rest, ice, compression, elevation, and support. The whole goal of using cryotherapy early in the inflammatory process is to break the pain spasm cycle and to allow the body to progress to the next phase of healing. When we are protecting injuries, sometimes we have to decide between immobilization and mobilization. There are some pros and cons to each option, and either might be appropriate under the right circumstance. Choosing to immobilize someone in a cast or brace can help eliminate negative stresses. There are some effects on the muscles. With immobilization, the muscles tend to atrophy or shrink. When muscles atrophy, we can see a decrease in muscular strength and endurance and can decrease the flexibility. It is not uncommon to have muscle contractures. Contractures are unconscious muscle contractions which result in a decreased range of motion. Ligament stability and tensile strength are decreased with immobilization, and we also see associated bone loss. Immobilization may be the best option for treatment, though, if a person won't stop participating in the injurious stressors or if continued movement is too dangerous for tissue. Choosing to mobilize someone includes continuing to allow someone to be exposed to potential stressors, but trying to reduce the stressors. There are also some effects of continuing to allow mobilization. The muscles resist hypertrophy and can better maintain muscular strength and endurance. With continued movement, the articular cartilage maintains its nutritional balance and nutrients are allowed to continue to diffuse into tissues. controlled continuous movements can allow for the realignment of collagen fibers during the healing process, which results in an increased tensile strength during healing. Bone density also doesn't decrease as it does during immobilization. Newest research suggests immobilization is the least desirable treatment unless there are not any other options. We have discussed Wolff's Law in previous lectures. The bone and soft tissue will respond to the physical demands that are being placed upon it during remodeling, or it will fail. During rehabilitation, we play with Wolff's Law on a daily basis. We need to determine how hard we can push the patient without injuring them. Too little stress will result in tissue loss. Too much stress will result in tissue breakdown and possibly new or worsening injury. The goal of rehabilitation is to impose controlled stress, which is just right. It reminds me of the story of Goldilocks and the Three Bears, trying to find that bed that is just right. For each of our patients, we are trying to find the rehabilitation process that is just stressful enough to heal the tissues, but not so much so that it injures the person further or prevents healing. During stage 2, the goal is to restore range of motion, commonly abbreviated ROM. AROM is active range of motion, which is when the patient can move themselves. We always start with AROM. We need to assess the patient and how much motion they are willing to do themselves. We can measure how much motion is available with the use of a goniometer, which is seen in the picture at the bottom left. If the person is not willing to move, then we try passive range of motion. AAROM is active assistive range of motion. During AAROM, the therapist assists the patient who is trying to move themselves. Sometimes when we are trying to reestablish movement patterns, we can help the patient move through movements we want by using this active assistive range of motion. PROM is passive range of motion. Passive range of motion is when the therapist moves the patient through the range of motion. During passive range of motion, the therapist is examining for infills. If a patient is willing to do active range of motion, then we continue to assess the patient with resistive range of motion, or RROM. During resistive range of motion, the therapist is assessing muscular strength or strength of muscle groups. All of these range of motion tools can be used to assess and measure the available range of motion at specific joints. Range of motion is different than flexibility. Flexibility is the total range of motion at a joint that occurs pain-free in each of the planes of motion. Please read box 9.3 Guidelines for Static Stretching to Improve Flexibility. There are different types of stretching. Ballistic stretching is repetitive bouncing. Ballistic stretching is a form of passive stretching or dynamic stretching in a bouncing motion. Ballistic stretching was very popular in the 1980s among athletes. It is still commonly used in soccer to get players ready for athletic participation. Since ballistic stretching involves bouncing, the muscles can be in danger as sometimes they fire in response to the bounce. If the muscle fires at the wrong time, the muscle could be damaged during the stretching. According to the American Academy of Orthopedic Surgeons, do not bounce your stretches. Ballistic or bouncy stretches can cause injury. Ballistic stretching is only recommended after an initial warm-up when the muscles are more receptive to this type of activity. Static stretching is used to stretch muscles while the body is at rest. It is composed of various techniques that gradually lengthen a muscle to an elongated position or to the point of discomfort, and then held in that position for 30+ seconds. This is the type of stretching that most of us are familiar with. For example, to stretch the hamstrings, we can bend over and try to touch our toes. We can hold this position for a period of time. PNF stretching, or proprioceptive neuromuscular facilitation stretching, is a set of stretching techniques commonly used in the clinical environment to enhance both active and passive range of motion in order to improve motor performance and aid in rehabilitation. PNF is considered an optimal stretching method when the aim is to increase the range of motion, especially in regards to short-term changes. Generally, an active PNF stretch involves a shortening contraction of the opposing muscle to place the target muscle on stretch. This is followed by an isometric contraction of the target muscle. PNF can be used to supplement daily stretching and is employed to make quick gains of range of motion, for example, to help athletes improve performance. In addition to be safe and time efficient, the rapidly achievable gains in range of motion may also help promote compliance with the exercise and rehabilitation program. The goal of PNF is to stimulate the mechanoreceptors such as the Golgi tendon organs and muscle spindles to increase their range of motion and or strengthen muscles. In phase 3 of the rehabilitation progression, the focus is on the development of strength, endurance, and power. Strength is the maximal force that a muscle or muscle groups can generate. Endurance is the ability to exert repetitive tension over an extended period of time. Power is the ability to produce force in a given time. Power is also referred to as someone's measure of explosiveness. Power can be measured by taking the amount of work a person can do and dividing it by the amount of time it takes them to do the work. In some sports and physical activities, the importance of strength, endurance, and power are very different. For example, if a person is a world's strongest man competitor, the emphasis in the rehabilitation protocol might be more focused on the strength than the power. However, all three of these are important and none of the three should be ignored. It is important to understand different types of muscle contractions when trying to work on muscular strength, endurance, and power. Isometric contractions are when the muscle contracts without changing in length. For example, in the picture on the right, if a person was holding a 10-pound dumbbell, they aren't going to perform any movement with that dumbbell. They're just going to hold it at one specific point in the range of motion. Isometric contractions are typically used when we are starting a strengthening portion of a rehabilitation. We can use isometric contraction when someone is immobilized, as the joint does not have to move to maintain strength. One of the main benefits of using isometric training is that the body is able to activate nearly all of the available motor units, something that is usually very difficult for us to do. Back in the 1950s, researchers Hedinger and Muller found that a single daily effort of 2/3 of a person's maximum effort exerted for 6 seconds at a time for 10 weeks increased the strength by about 5% per week. Clark and Associates have recently demonstrated that static strength continued to increase even after the conclusion of a 5-week program of isometric exercises. There are a limit to the amount of strength gains that we can see through isometric contractions, however. Isometric contractions can only produce around 50% of the total strength increases that can be seen from concentric or eccentric muscle contractions. Concentric contractions are when the muscle contracts while shortening. For example, in the picture on the right, a person who is holding a 10-pound dumbbell is going to perform a concentric contraction when the fist is moved with the weight towards the shoulder, thus shortening the biceps. Concentric contractions are commonly used in strength training. Some people try to cheat the movements, as most people are strongest in the mid-range of motion for concentric contractions. When you are in the gym, you will commonly find people cheating and performing what I like to refer to as a hip thrust to help get the bar or dumbbell moving because they are lifting too heavy of a weight to move through the whole concentric range of motion. Eccentric contraction is when the muscle contracts while lengthening. For example, in the picture on the right, a person who is holding a 10-pound dumbbell is going to perform an eccentric contraction when the fist with the weight is lowered from the shoulder back down, thus lengthening the biceps from the shortened position. Eccentric exercises are commonly used during strength training. Some eccentric contractions are called negatives. It is not uncommon for individuals to overload their weights by 10 or even 20 pounds. They may have a spotter help them get into the terminal position, and then they work on the eccentric contraction. So, which one of these is most likely to cause muscle soreness? The eccentric contractions are the most likely to cause the muscle soreness. Lactic acid is built up during eccentric exercises at a greater rate than any other type of muscle contraction. Therefore, eccentric contractions should be done with care in the strengthening phase of the rehabilitation process. There are different types of training protocols that can result in muscular strength, endurance, and power gains. Two types are isokinetic training and isotonic training. Isotonic training is completed typically with a machine or dumbbell weights or even with body weight. It includes moving at variable speeds with a fixed resistance. Many people like to try to lift things that are heavy really quickly or swing a little bit to get the movement started. By moving quickly, we can take advantage of the momentum of the movement, and it makes things a little bit easier. When lifting a barbell or doing a leg press, such as in the picture, the weight does not change. Your 20-pound dumbbell or the plate at which you set the machine does not change during the exercise. Isokinetic training is a little bit different and must be completed with a specific type of machine. Cybex and Biodex are examples of isokinetic machines. These machines are typically expensive and won't be found in traditional gyms. They are usually found in research clinics or rehabilitation clinics. With isokinetic machine, we can control the speed of the movement. With this controlled movement speed, the resistance of the movement is varied. Remember the example of the person who is lifting too much weight in the weight room, and they have to perform a little hip thrust to get the barbell started. The reason they may have to do this is due to decreases in strength at the beginning and end of range of the motion. With an isokinetic machine, the varied resistance accommodates for these decreases in strength during the range of motion. The other issue is the amount of effort provided by the patient. The machine will only match the output of the person completing the motion. So if the person isn't trying their hardest, the machine isn't going to recognize this decreased effort. It is important to try to get your patients to do their best while performing these exercises to get the most benefit. From a biomechanical standpoint, there are different types of activities, as well as including open and closed kinetic chain exercises. Remember the song, Head, Shoulders, Knees and Toes, that you used to sing as a kid? Well, that song is extremely appropriate. Everything in the body is connected, which is known as the kinetic chain. When there is an issue or injury, we have to look at the entire body, including the joints above and below the injury, to be included in the rehabilitation process. In an open kinetic chain, the distal segment of the kinetic chain is in a non-weight-bearing position. An example of open kinetic chain exercise would be a knee extension machine, such as the picture in the upper right. In a closed kinetic chain, the distal segment of the kinetic chain is in a weight-bearing position. An example of closed kinetic chain exercises would be the body weight squats, such as the picture in the lower right. The last phase of the rehabilitation process is the return to sport, physical activity, or daily activity. In this phase, the focus is on the return of proprioception, which is the sense of the relative position of parts of the body within space, and the strength of effort being employed in movement. Coordination, which is the ability to use different body parts together smoothly and efficiently. Sport-specific drills and skills, the maintenance and possible increase in efficiency of cardiovascular endurance, and the return to play activities. Depending on the person, their injury, and their goals, this last phase may be designed to return them to participation, or it may be just to return them to activities of daily living. For an example, an athlete who sustains a catastrophic spine injury and has suffered paralysis might have the goal of learning how to get around rather than the return to an athletic venue. If an athlete or patient is returning to sports or other physical activity, it is important to determine if the person is ready to return to play. In order to be cleared, they must meet several criteria. Their activity and movements need to be pain-free or possibly at a pain-adequate tolerance level. Pain can take a while to dissipate, but the individual should be able to tolerate the pain during activity. Remember that everyone has a different pain tolerance level. The patient should have full active, passive, and resistive range of motion at the injured area. The patient should be returned to full strength, endurance, and power. It is good to test the non-injured side if possible. The patient needs to be at least 80% or better of their original strength, endurance, and power to return safely to sports participation. The patient should have full coordination, proprioception, and balance before returning to activity. This is especially true after concussion. Sometimes we forget to test these functions when making return to play or return to activity decisions. It is important that these faculties are returned to full levels so the individual isn't at a higher risk for re-injury. And lastly, the patient should participate in a functional progression with sport-specific tests. For example, a basketball player who is returning from injury might start a running progression in which they would first run forward, then they might run in larger circles, progressing to figure 8 running, and then side shuffling, back pedal running, and then finally cutting.